Welcome, everybody. This Lyceum is really here to present the great work that's been done on reducing physician burnout by the St. Luke's Health System. And I really don't need to say much more than that because the experts who have done this work are here to present. And so, the one thing I would say is, the work that I've done where I work all over the country with health systems that are trying to address this, or perhaps not trying to address it when they should. The work that you'll see presented today is some of the best work that I've seen anywhere. And without any further ado, I want to hand it over to Jim Souza, the Chief Medical Officer at St. Luke's Health, to take it from here and introduce this work. Thanks. Take it, Jim.
Thank you, Paul. I think Katie's going to run our slides. I'm going to just make a few comments up front. Katie's done the lion's share of work and deserves the credit. My name's Jim Souza. I'm the chief physician at St. Luke's Health System. We're a community-owned nonprofit based in Boise, Idaho, across a geographic footprint that covers southwest Idaho. I report to our president and CEO, Chris Roth, and Dr. Schneider reports directly to me. I'm going to start with a couple of comments on the important link between this topic and organizational performance. They are inextricably linked, in my opinion, and to me, it goes without saying that in an industry where we're delivering a human product, which is care, that delivery is wholly dependent on the well-being of the humans that are delivering it, because it is through, their heads and their hearts and their hands that this product gets delivered. So it's certainly true for staff members, and I think it might be especially true for physicians and advanced practice providers who actually, write the orders that create the care plans and create the resource utilization in healthcare. And if we're trying to move to a more value-based world, and our organization is, and many are, with efforts to reduce unwarranted variation and eliminate low value versions of care, then we actually need the consent, I would argue, of the order writers in order to be successful. And to me, that goes without saying, and especially so in an organization that has taken on so much population health risk. We're about 1/3 in upside downside risk reimbursement contracts through our clinically integrated network. But if you needed data, there is data to affirm what I just said. There's a rich set of data linking burned out teams to higher levels of serious safety events, to lower levels of quality, and to lower patient experience, and to higher cost. So, and even in our internal data, we knew that there were areas with burnout that also had problems with performance and high turnover. The second thing I wanted to acknowledge, which is a frustration for me, is it's a benefit for those who are members of our medical group, and it's a frustration for all of the independents who are in our clinically integrated network, is that we have within our employed and contracted medical group a greater opportunity to move the needle on this, and therefore I feel a greater responsibility to move the needle on this. From a regulatory and legal standpoint, the opportunities for us to support, incentivize within that employment relationship is just significantly different. We've got more, levers to pull and buttons to push in that relationship than we do with our independent colleagues in the clinically integrated network. The third thing I wanted to mention is a nod to what got us started on this path. And it's a specific nod to Paul, who was the right voice at the right moment to be a powerful accelerant for us. So
All right.
back in 2016, we were already at a leadership level down the path of wanting to be more active in this space, but not sure how to do that. We had, done some quasi-organic things. We'd established wellness committees in our medical staffs, and we performed our first ever organizational assessment of burnout around the time we went live with our electronic health record. In 2017, I took on my role, and I made this one of my priority areas during my interview and selection process. And sadly, shortly after assuming my role, we had the tragic suicide of a physician colleague. That event catalyzed in our still small community a community wide conversation in which we participated and through which Paul DeChant was invited to come and talk to us. And I don't remember this with high specificity, the meeting he was at, but I do remember the exact room it was in. And he met with our C suite on this topic. And I don't know if he did the same thing with our crosstown neighbor, but I was there when he met with our leadership team. And I can tell you his voice was incredibly valuable to me in helping accelerate this work to where it needed to be. I think I had, up until that moment, been suffering a little bit from profit in their own land syndrome. And Paul's excellently crafted and well timed message was a critical catalyst that then moved us forward in 2018 and beyond. Um, which brings me to what we ultimately established that really has been then the nidus and the little engine for all of the good work that's happened since then. Couple comments on that. First, on positioning this function in a healthcare organization for success. It needs, I think all the experts in the industry say this, and I believe this, and it's been our lived experience. It needs to have top level system visibility and prioritization. You cannot embed this under other sub entities. So I'm the chief physician. I oversee the medical group, the network CMO, the quality officer, blah blah blah. Like putting it under one of those individuals, we decided was not well placed, and so we put it directly under me. A comment on support. We decided we needed a physician leader. I was a super stingy jerk and did not give it enough FTE to start with, but I hired a leader who I knew would show me that we needed to make a bigger investment in her, and she did quickly. But we also knew, like, we can't ask a physician leader to go do this by themselves. They need an operational full-time equivalent to partner with them. And in our organization, we've used a lot, maybe overused, the dyadic structure of leadership, physician leader with operational leader. So my dyad partner is the system chief operations officer. So we supported it in that way with a full-time FTE to partner with Dr. Schneider. And then finally, in structure, we also had an important choice point there. We implemented what's called a center of excellence in our organization. And I could say more about that if there's questions about it. But we made a distinct decision not to make this a department, which would have, a long list of decisional rights, but to make it a center of excellence that would inform and drive the entire organization. We did not want anyone to think that well-being of the people they lead is someone else's job. We wanted them to believe and understand it's actually their job. and this is the cavalry we're bringing to help you. And that all kind of kicked off, and Katie took the mantle and she took it from there. And I'll let her speak. I'm going to introduce Katie. Dr. Katie Schneider is um, a family physician by training who, in her clinical work, which she continues to do, works largely as an acute care hospitalist in the Wood River Valley, which is one of our critical access hospitals that serves a very unique population of people. The entire financial spectrum is in her community. Um, Katie's a certified coach, and Katie, in just a few years, has advanced us in significant ways in our well-being performance. So with that, I'm going to turn it over to Dr. Schneider to show you some of the work she's been leading. Dr. Schneider?
Thanks, Jim. And I guess, thanks for the introduction. I just need to say, both Dr. DeChant, Dr. Souza have been such huge influences for me in this work, and probably without either of them, we wouldn't be where we are today. What Paul probably only remembers, because I remind him every opportunity I get, is when he came and had that meeting at the C-suite with Dr. Souza and his team at St. Luke's. I also had the opportunity to have dinner with him, with a group of people in the community that were really interested in well-being at the time. And I didn't even know what that looked like from an institutional or organizational standpoint. And Paul already had so much of that knowledge. So I continue to fangirl a little bit of this whole opportunity I've had with Paul. And then I think Jim speaks for himself as what an incredible boss he is and partner he is for me to get to work with, and the support I get for this work. I do want to spend a little time sharing just a sliver of our story and hopefully open it up at the end for questions, specifically about what we're doing in the well-being space, including wellness center leadership, as well as other things. So I'm hoping I can advance my slides here. So one thing that's been really critical to the work we've done is we implemented a survey annually, really as soon as I started in my role in early 2021. We've used the American Medical Association's Mini-Z survey. They've been an incredible partner for us. And we do that survey annually. We do it every year at the same time, mid-April to mid-May. And our participation rate has ranged from 29%, 30% is about the benchmark you need for it to be validated, up to 60%. And what I can share with you is we transitioned from emailing reminders to people to, I started doing personal reach outs, which is a little bit overwhelming, but also very heartwarming. And a lot can be learned there. And we got our participation rate up to the 50 to 60% more consistently, which I think has really helped us confirm that the values that we're seeing are real. And we offset this every year by a pulse check. So we do a short 8-9 question survey, just seeing where we are in our key metrics, offset the other years by a 50 to 60 question survey where we really look at all the drivers. And with those bigger surveys, we've had the opportunity to correlate kind of what drivers are correlating most strongly with our key metrics around well-being. And what we found back in 2022 is that leadership alignment was our biggest driver, or most correlated with our key metrics. And that allowed us the opportunity to use that internal knowledge along with external validated evidence to start down a path of how we start to address this. You'll see there, and I'm happy to talk about this later, although it's not in the presentation today, is that this past year, you'll see we've done a lot of good work in the leadership alignment space. Our biggest correlation is now around practice efficiency. That's probably not surprising to people on this call, but in-basket work, EHR, teamwork, how we kind of make our days flow easier. So in terms of wellness-centered leadership, I mentioned the correlational analysis, and I want to tell you a little bit about what we did. We partnered across several areas within our institution to focus on leadership and leading with well-being. And these are busy slides, and we can share these if they're of value to you, but I just want to run through a little bit of what we did. We partnered with an external vendor who was doing leadership development for our most senior leaders, as well as some of our site and regional medical directors, and we focused on wellness-centered wellness-centered leadership, we use the evidence from Tate Shanafelt around how you lead with well-being, the key things you can do as a leader from a well-being standpoint that has known impacts on your team that reduces burnout, increases job satisfaction. We share that with them, and then we ask them to workshop things, start to understand what burnout means for themselves, their teams, and what their opportunities are to lead with well-being. And we got all of our service line leaders and their dyad partners through that workshop. We also had nearly 100 of our frontline medical directors who were able to run through this workshop. And then we doubled down with a system-wide leader workshop where this was a really fun thing. We do a quarterly physician leader meeting, and my dyad partner Chris and I had the opportunity to come and spend about 45 minutes where we really engaged people ahead of time, found out what they thought around leading with well-being, how they thought they were doing, which turns out everybody thinks they're doing a really good job at leading with well-being, but I still think we have some opportunities. And we shared the data with them, and then we asked them to do things like we put a communication up that was very direct and said, hey, how can you change this communication to have a little more wellness-centered communication? And we asked people to type it in the chat. In some of our workshops, we've created case studies where there's been leadership opportunities where maybe people have led with well-being and maybe they haven't, and trying to understand where the opportunities are and where the areas we're doing well and we need to continue to focus on. So we've really tried to instill this idea of leading with well-being, showing up with wellness-centered leadership as part of our culture. This continues to show some of the areas we've really focused on wellness-centered leadership. And we created a toolkit. This is something I'm willing to share. We've shared it in a number of forums, but it's a wellness-centered leadership toolkit. And we have relied on this significantly in a lot of the workshops that we've done. It starts with the background of why it is so critical as a leader that you can lead with well-being. And I can't emphasize enough that how you lead as a leader, I think, is one of the biggest and quickest ways we can change our culture and improve the well-being of our teams. And then we have pulled several best practices that we have found from evidence nationally and internationally, many which are specific to healthcare, that can help you lead with well-being. These are small changes you can make in your leadership style that can have a really big impact. And with a lot of the leadership trainings that we do, we ask people at the end, pick one of these things. Are you going to check in on people rather than check up on people? Are you going to incorporate consistent well-being rounding? Are you modeling well-being? Are you not sending emails at 10 p.m.? When you're on vacation, are you truly off? And we ask people to pick one of these and say, how do I commit to doing this for the next 2 months, 3 months, 6 months? How can we help you be accountable to that? And once you've really mastered that skill, can you add another one to your repertoire? So we've relied on this toolkit in our training significantly as we've continued to help our leaders grow into this space. And the punchline of this is, while this is by no means the only thing we're doing in this space, we have individual supports. We know people, both frontline physicians and APPs, but as well as our leadership team, need support. It can be really lonely and isolating in all of these roles at times. And so we have peer-to-peer support. We have access to free anonymous counseling. We have a whole variety of things we're doing in addition to this work. But I think this work has been one of the things that's been most critical to see the changes you're going to see on the next slides. So our burnout rate, we're in blue. And then the AMA, the American Medical Association's benchmark numbers, are in orange. We've reduced our burnout from a peak of 54, almost 55% down to under 35%. I'm so proud of this number, and it's just amazing to see that when we have a strategic focus and use our internal data with the evidence about how to do this work and stay consistent with it, we can actually see improvements. We've also improved our feeling valued. We know this is incredibly tightly woven to burnout, from 44% to 56% over the last 3 years. I think that how our leaders are leading is probably making the biggest impact on this. Our leadership alignment, as you can see, went up by about 12% when it was fairly flat for the AMA across the last several years. I think this speaks to the fact that a lot of the work we've done is having an impact. Another thing I'll note is that when we look at our leadership alignment, we have broken down our survey to leadership level. So we look at site, your direct leader, your site medical director, the person you report to, how aligned with you are you with them, how aligned with you are you with your service line leaders, and then how aligned with you how aligned are you with your executive team? And I think most people in our institution assume our executive team to be Dr. Souza, his president's cabinet, our CEO. And what we see and what we like seeing is that people are more aligned with their direct leader, and the alignment goes down as we go up across the institution. I think that's okay. But what we found is that our alignment went up across all levels over these years. So this is just one snapshot of that. And our executive team had the biggest opportunity to improve leadership alignment, and they also had the biggest growth in that space. So really, leaders at every level are focusing on this opportunity, and we're seeing the change across the board. And then lastly, our intent to leave really went down quite tremendously. So we peaked at 40% last year, similar to AMA, and now we're down to 25%, which to me really shows we're starting to stabilize our workforce in the state of Idaho with what's going on politically, as well as with our ability to recruit. Being able to keep the people we have is huge. We know that this data translate to actual attrition, and we can calculate that. And we actually use this data service line specific to give our leaders a heads up of what to expect and how to think about recruiting and how to go find people that are thinking about leaving and what we can do to support them. So really exciting just to see that we've moved the dial on these metrics. This next slide is quite busy. It kind of shows our journey over the last few years, which I think is valuable, as well as where we're headed. And I'll tell you, when we started in 2021, in so many ways, we were getting our feet under us. I mean, we had our first survey, we were starting to understand our internal data. We, not that many months after I started my role, went into crisis standards of care for COVID for a couple months. We were in kind of just, putting out fires. And we've really moved over the last 3 to 4 years into how we change our culture, how we change our practice efficiency, and how we think about systemic change to make an improvement. So we're not putting out as many fires for our physician teams. As I mentioned, looking forward, we're really thinking about the practice efficiency piece for our teams. We did an AI scribe pilot last year that was quite successful. And so we are rolling out an AI scribe for our colleagues system-wide. And I am happy to kind of chat about where we're going, if that's of value to you, as well as some of the more details of the work we've done. And I really want to leave time for us to all have a conversation, but I just want to leave you with a couple tips. First, that is my daughter and husband on Halloween. She is a bear. My husband is a honeypot, if you don't get the reference. And I tend to put them in slides. I don't even ask them or ask permission. I probably should, but we do this work for the people that we're working with. And I was, telling Jim, I think just earlier this week, that I think both of us in our roles hear so much of what's going on with the people that work with us across the system, both in their personal lives and in their professional lives. And we have had some sad events occur for the people that work for us in the last month. And mirroring that with kind of the intensity that's going on at work has been really hard for me, because I think, gosh, life is so hard sometimes as it is. Anything we can do at work to make that better and not add stress is really critical. So I put my family on there to just know that they're front of mind for me, but also I know they're front of mind for so many people that we get to serve in this work. And then I just want to say, here are my tips and takeaways. Like, you can do this. I have to say, my dyad partner, Chris, his name's Chris Hartime. He's a dynamo. Without him, like, I could not be as effective in the work that we are doing. But it's a small team. I work half-time on this work. He works full-time. We have asked for very minimal funding to get this work done. We partner across our organization to be successful in this work. And so I just feel so strongly that so many organizations with the right strategy and data can really be effective. And that just speaks to the point of having a strategy, being consistent with it is really important. You probably saw in our data that some years we went up before we started coming down, but we didn't ping around with our strategy as that was happening. We really were focused on where we were going because we knew and believed we were doing the right work. Use your internal data, partner it with the evidence that we know works. I think there's evidence in so many ways of how we can address well-being, that find out what your institution needs most and utilize that evidence to be successful in making those changes. And then, while I would suggest 90% of the work I do is institutional change, whether that's institution-wide or service line or kind of on a bigger scope, don't forget to have the supports in place for the individuals on your teams for when they need them. We don't get out of medicine unscathed, and we all need support at some point. So encourage you to kind of think about your program pretty holistically. Okay, I will put up all of our emails. I think each of us would be very happy to speak to you in follow-up at any point, but I know that we're going to have some nice time for discussion. So I am going to exit out of my slide deck and turn it back to you, Paul, for next steps.
Thank you, Katie. That was amazing. And there's just a couple of things that I would like to highlight or comment on because this work is so good. First of all, you kind of glossed over and deserve great recognition for the achievements, the national recognition achievement with the AMA Joint Medicine Program. And in 2022, you got the bronze. For those of you who don't know, AMA has a formal recognition program with very stringent requirements to be recognized at various levels for commitment and achievement and physician well-being. And there's 3 levels: gold, silver, and bronze, and they're not easy to attain. Very few people are at the gold level. In 2022, just having gotten started, St. Luke's was at the bronze level, and 2 years later, you stepped up to the silver level. Very few organizations have been consistently in the recognition program year on year. So this is really a significant achievement and a testament to the work that you're doing. In case anybody had any doubt after that fantastic presentation about how valuable and excellent this work is. One thing, and then another thing about, in terms of the outcomes, the data that you presented is just so compelling. And I particularly appreciate the 4 areas that you demonstrated the improvement on. And that's just the burnout rate, which certainly people focus on a lot. But the more important things in terms of leadership alignment and in terms of intent to leave, as every healthcare system is struggling with losing physicians, or so many are, and keeping that, if nothing else, you could probably, I don't know if you ever run a financial analysis on this. There are ways to do that. But maybe Jim or Katie, you could comment on that at some when I get done. The return on investment that you've made, I would imagine, has to be quite impressive. And one last note, there's so many things I could say, but I think that I remember I came there because I connected with the executive director of the Ada County Medical Society, which is Steve Rames. And Steve is a dynamo into the commitment to physician well-being in the Boise community. I was just, I was so impressed with him. He's really been on the national stage as well as the local stage doing this work, and was the key to getting me there. And he's brought other leaders and speakers about burnout to the community as well, which I'm sure have further enhanced things. But recognizing your local, external to your system resources that could be helpful, I think, is also it's really worth doing. So with that, yeah, I'd love to hear about the ability to, if you've been able to calculate the ROI. And then I do want to open it up for everybody else's questions, because I think those, I'm sure people are really interested.
We haven't, and we should. We really should. The reason why we haven't, though, is it speaks to our why here. Maybe more than to organizational sloppiness, which you could say, well, gee, why haven't you done that? And actually, we should do that because it's important to justify the continuing ongoing investment in spaces like this. But For our organization, I just there's a belief that we have to make so many investments with our obligations to the communities, but that we know that the most important investments we make are in people. Um, and just giving one more tangible example of that, our AI scribe that we're implementing at some cost. I know I've got peers and colleagues in the industry who have done similar work, and the conversation kind of goes with, well, how are you paying for that? And I am fortunate enough to work with a CFO that when I, you know, when I said to our leadership and our CFO, like, we're not going to charge for this with more productivity, with an extra patient a week. Our teams have been putting 5 more pounds in their pack year after year after year, and it's time for us to take something out. So this is the time. And I also believe that we're fortunate enough to be able to make that investment. I believe investments in people like this will be the things. I don't love the consolidation that's happening in the healthcare industry, and we're the biggest healthcare system in the state. So look at me, a pot calling the kettle black. I don't love the trend though, but one of the things that's going to continue to drive the trend is investments like this, investments in well-being, investments in AI scribes, because doctors and APPs are smart customers, and there's not enough of them out there to take care of all the people we need to take care of. And they're going to make choices. And they'll make choices, I think, based on, what have you done for me lately? What have you done to take 5 more pounds out of my pack instead of and then let's talk about the 2 or 3 more you want me to do. It's a relationship. And so, Paul, I answered your question in a very long roundabout way. We haven't done it. You have inspired me to do the work, though. We can monetize that number, and we should.
I'll add a little bit.
Just
I'll
yeah.
add a little bit to that, Paul. You
Uh,
mentioned the AMA Joy in Medicine recognition. We have done it. We've done it for 2 years. As you mentioned, we're at the silver level. We'll reapply next year, probably for gold. But if you're at an institution who's trying to figure out how to do this work, the Joy in Medicine is a nice framework because it has 6 evidence-based buckets of areas you can focus on. And I like it because while we focused hugely on leadership the last 2 years, that's one of the buckets. It made a lot of sense. It kept us accountable for not forgetting about some of the other opportunities and areas we need to be doing at some point in the future. So the practice efficiency part that's now really coming up for us as an institution is something that's been on our mind, and we have a little bit of foundation in it because this recognition is holding us accountable to thinking globally about it, even though it hasn't been a strategic priority until now. So I recommend finding a framework that works for you if you're just starting this work. The AMA also does make us calculate our ROI and changes. So Jim, Chris and I have done that. It's in the
Okay.
few millions of dollars when you look at attrition related to burnout. Transparently, I expected the number to be a little bit higher than it was based on the marked improvement in our intent to leave. But a few, $2, $3, $4 million is still fairly significant when you think about retaining your team. So those are just the 2 pieces I wanted to add.
Yeah. Well, I'll throw one more load onto you here. Both this work, the presentation you did here, and then Jim, just the response that you've both made to that question demonstrates a type of leadership that's sorely needed across the country in so many health systems. And spreading the word about what you have accomplished is tremendously important. And I on the side, as we were preparing, I mentioned considering applying to present at the International Conference on Physician Health, which is coming up this year. And I think it's the American Conference this year. Um, Absolutely, this would be at a minimum a breakout session. And having seen the presentation and thought more about it, It's even something I think that could get on as a keynote on the main stage. So this is and it would be a service to the rest of the country to be able to present this and inspire others to learn from what you've done and help them find a model that really works. So with that challenge, we can talk about that later and I can help you get there. Let's open it up for others' questions. If anybody has a question, raise your virtual hand and let's take them.
Can I have one more comment that I forgot? And
No. Yeah, please.
You mentioned Steve Reams. He's the executive director of our local medical society, and he's a tremendous partner in this work. And in addition to bringing in Paul, he's brought in other people. Another person I want to call out is Corey Feist. Many of you have probably heard of him. He is I think also the executive director of the Dr. Lorna Breen Foundation. He came into our local community and helped both of our hospitals think about how we change our language on our credentialing forms to remove intrusive language or barriers to accessing mental health, which we've successfully been able to do. That's been a piece of the puzzle as we continue to layer on trying to create a foundation where people feel safe in the place they work. But I say all that to say, your community, the people you work with, the relationships you create are really critical in doing this work. I can't do this work by myself, even though Jim is a tremendous support. I don't think Jim could do this work by himself. And so how you make those connections and leverage the people is really helpful. And I'm personally very grateful. I now have a relationship with Corey and can rely on him for some support and other things as we think about this work in our community. So, utilize your connections for being successful in the well-being space.
And one more comment from me. In addition to the great results we're beginning to see, and we're not done. We're not satisfied with where we are. It's all an integrated recipe. And it comes back to my opening comment on organizational performance. So, we have launched in our health system other important work around becoming a highly reliable organization. I'm not so naive as to think that the improvements we've seen in serious safety event rates and things like that occur exclusively because of that. The work Katie's doing is also driving that. Our improvements in quality performance, our improvements in financial performance, these are all integrated and trying to change organizational performance, leaving this critical piece of the recipe out is like trying to bake a cake without a leavening agent. You will not succeed. So it all goes together. And thanks for being the baking powder, Katie.